that is going to come sooner than later. This is a treatment which we have been following for a long time, not just a couple of years, but a long time. But it is a way, it's a new way, and a new approach with the same medication. That's what is interesting, and lots and lots of studies have been done, and I'm sure you are, those of you who are pulmonologists, and I understand that every one of you is pulmonologist. I'm sure you have seen these studies published in big journals. So without wasting any more time, let's start with this trial, FACET trial, and this was one of the largest trials at the time. And what they did, they divided, and I'll come to that, come to how large the trial was. They divided the patient population into two groups. One group got a low dose budesonide, and the other group got a high dose of budesonide. And if you can see that there is not much difference in the lung function, that the FEV1, or in other words, the steroid dose response curve is at its top. So increasing the steroid, inhaled steroid by 4-fold hasn't achieved much. But see this. When they added formoterol is another long-acting beta-2 agonist, like salmeterol, but there is difference, and I'll come to that. But when they used formoterol, when they added formoterol with the low-dose and high-dose steroid, there is a significant lung function improvement. So the steroid was doing something, yes, but not absolutely everything. But when we added the formoterol, we got some more benefit, and we will discuss this. So we can say safely that adding formoterol was better than even increasing the steroid inhaled dose by 4-fold. However, there is a problem with the study. The problem was they included all those patients who had severe persistent asthma, and you have seen the asthma algorithm. They were around step 4, step 5 patients. And the problem with that is in day-to-day life, we see mild persistent and moderate persistent mainly. And so what they did another study called Optima study, and the result of that was almost similar. So what we achieved, what we saw, that this is what we know. We all know that the central role in asthma symptomatology is played by the inflammation. And this can be stopped or even at least reduced by adding steroid. However, steroid doesn't achieve everything. So if you add steroid, this will be blocked and the symptomatology will be reduced. However, there must be another component which is addressed by the long-acting beta-2 agonist, and then the symptomatology comes down really significantly. So it makes sense to say that what we always used to do is to start the patient who are mild and moderate persistent asthmatic with a low dose inhaled steroid, and then we increased, if the symptoms didn't get better, we increased the inhaled corticosteroids to high dose corticosteroids. Unfortunately, with this technique, what happens quite often, the moment the patient is better, they stop coming to you, and so they end up in having a high dose of steroid, and please remember that there is some side effect, systemic side effect of high dose inhaled corticosteroid. However, now we know that adding long-acting beta-2 agonist achieves even better result than giving high-dose steroid. So that is a logical, and this is the best way to manage asthma these days, and we all do that. Add long-acting beta-2. And what are the other steps that we can achieve? We can use low-dose theophylline, and this is the cheapest bronchodilator, and it has got some bronchodilator efficacy. However, we must not forget that inhaled either the steroid or formoterol, especially combined, have got much better efficacy than the oral medication. And the last one is adding a leukotriene. The problem with leukotriene is the efficacy is small, however it is very costly. So it is an expensive treatment with little benefit. Now, So it's rational to say that we have got a combined preparation, like you have got fluticasone and solmeterol. It's the same. What they do, this is almost a cascade, and you see there's a line there, and we'll come to that. If I add long-acting beta-2 agonist, it will definitely act as a bronchodilator. We all know that. But we now know that it is not just a bronchodilator. It also has effect on the mast cells, whereby it inhibits the liberation of cytokine, and I'll come to that again. It actually inhibits the plasma leakage, and also possibly have some effect on the sensory nerve activation. Or in other words, the acute inflammation is pretty well addressed by adding long-acting beta-2 agonists. However, what it doesn't do, and we must remember, must not forget, that it doesn't do this. And the downside, this bit is not addressed, and I emphasize not addressed, by the long-acting beta-2 agonist. What is this? This is the chronic inflammation pathway. This is the T-cell eosinophil recruitment, and this is the chronic inflammation. Or in other words, we must not, and we should not, and must not use long-acting beta-2 agonist on its own. It must be combined with a steroid. Otherwise, there will be a disaster. And I really strongly feel that we should not be allowed to use a long-acting beta-2 agonist on its own, because it has its danger. Remember the SMART trial with solmeterol on its own. There will be, and there were high mortality, but increased mortality on that arm. So if I give steroid, this is addressed. So that's why we combine. What we always used to do, even a few years ago, is to use this, either budesonide formoterol or fluticasone solmeterol, and they are perfectly good. They are very, very effective treatment as maintenance treatment, a conventional maintenance treatment. And what they did, if you use either of these combinations, the patient is really well. And for rescue treatment, they can use either terbutaline or salbutamol. And the efficacy of these two regimens have been proven. This FACET trial and OPTIMA trial have given us data on budesonide formoterol, and you all know the GOLD trial, which has actually established the efficacy of fluticasone and salbutamol. However, we have moved on. What it does, what we do now, or we're trying to do now, is to use the same therapy with budesonide formoterol as maintenance, but instead of salbutamol and terbutaline, we are using the same budesonide and formoterol as rescue treatment. And that is more effective, and this is why it is called SMART treatment, or in other words, single inhaler maintenance and reliever therapy. Single inhaler maintenance and reliever therapy. And this has been actually tested in all these studies, and they have been published and have been peer reviewed, and we haven't got any doubt that this is very, very effective treatment of asthma. Now, this is the STAY study. This is the STAY study, and it is a very large study. You remember that you can see there's about 3,000 patients, and what they did, they used a fixed dose combination. This is a budesonide formoterol fixed dose and a short-acting beta-2 agonist, and a high dose budesonide with a short-acting beta-2 agonist. And you can see that the budesonide formoterol has fared slightly better, but it's not significant in